Chapter 13, the respiratory system. Main functions of this respiratory system. Gas exchange, we're taking in all that oxygen and exchanging it for that carbon dioxide, get rid of all that waste. We're going to also purify, humidify, and warm all that incoming air and allow for that gas exchange to occur much easier. Several structures that are part of this respiratory system. We have the nose, and after that's going to be the pharynx, more posterior to that, followed by the larynx, the trachea, this long windpipe. That's going to branch off to form the bronchi, both the right and the left. And from here, we're going to enter into the lungs. Now, in the lung, each lung, we have several smaller structures. We don't need to know this terminology, but we have the primary, secondary, tertiary bronchi. And eventually, they're going to keep on branching just like the tree until they terminate in the smallest regions, like the twigs. And these are called bronchioles. And at the bronchioles, at the very end of those, kind of like little lollipops, we have alveoli, and this is where all that gas exchange occurs. And so really all these other structures, no gas exchange. So no gas exchange occurs at any of these other areas. Only gas exchange occurs at this alveoli level. Now let's get a closer look at those different structures. So let's start first off with the nose. This is where all that air enters. So air enters here. You can make that note. Air enters. Also here within this nose, we have the nostrils. And separating each of our nasal cavities, or the entrance to our nasal cavity, we have the nasal septum. So if you feel your bone or you feel your nose, you try moving it back and forth, you feel that nice little flat separation between them. Now also what we have here are, of course, at the roof and surface, or the roof of our nasal cavity, we have olfactory receptors for the sense of smell. And what else do we have here? Separating our oral cavity from our nasal cavity, we have this palate. Anterior, it's composed of this bone, so it's hard palate. Posterior, muscle, and so this is called the soft palate. Taking a closer look at the nasal cavity, we have mucosa. Remember that mucous membrane that we spoke about earlier, and because it's a mucous membrane, we're also going to have the epithelial tissue lining this entire layer. And here we have ciliated columnar epithelia. And of course, because it's ciliated columnar epithelia, we have these nice little projections on the surface. Ciliated, why is this important? Well, this type of columnar epithelia, besides these, we have these goblet cells that's going to secrete all this mucus. So with a combination of that mucus and the cilia, we have this nice sweeping motion to, here's a little pathogen, or we can say it's a dust particle or anything trying to enter into our nasal cavity. We can trap that into this mucus produced by all these goblet cells and then sweep it across and get rid of it out into your nasal cavity. So when you have all that snot, great, collecting all that dust trying to get into your nose. Other functions, we're going to moisten all that air coming in. We also have paranasal sinuses within this area, not part of that respiratory system. But what is the function of paranasal sinuses? It's going to produce mucus. And it also acts as a resonance chamber, resonance, meaning when you speak, that nice resonance that you get with your voice, that's because of this paranasal sinus. And we have 4 paranasal sinuses. We have the frontal, right here by this frontal bone, ethmoid, by that ethmoid bone, sphenoid sinus, and we have the maxillary sinus. So maxillary right by the maxilla. Next region we have is the pharynx, and we also consider this the throat because a portion of it is found right behind our mouth. And this pharynx is broken down to 3 different regions. We have the nasopharynx up here in red, we have the oropharynx, and we have the laryngopharynx. Now, a couple of things I want you to know, because this is going to come up again for the digestive system. Only the nasopharynx is involved in the respiratory system. However, both the oropharynx and the laryngopharynx are involved in the digestive system. So all 3 of these part of respiration, but only these 2, the oropharynx and laryngopharynx, are part of the digestive system. You'll probably see this again later down the line. And what is this? It's just a passageway for the air to come down as it makes its way towards the larynx. The next structure we have is the larynx, also called the voice box, because this is the area that gives rise to speech. Couple structures before we go over speech. We have here the very top and superior region of the larynx is the epiglottis, and this is a flap-like structure that can direct food towards our esophagus or air towards our trachea. Another noticeable structure here comprised of hyaline cartilage is the thyroid cartilage, and this is what we know as the Adam's apple. Looking down into the entrance into our larynx, we have this noticeable structure here. This is called a vocal cord, also known as a vocal fold, and as we exhale, that causes vibration along these vocal cords that makes sound, and we know this as speech. Another structure, it's not really a structure, but this area and a hole and opening between these vocal cords is called the glottis. And if you remember your eye, if our iris is contracted or relaxed, it'll determine the shape of our pupil. And so this is the same thing in this case. The glottis is just like this pupil, and that the size of this glottis can change in relation to whether this vocal cord is nice and taut and stretched or if it's more relaxed and spread wider. Here's a lateral view of this larynx. Here's our larynx. Here's our epiglottis. Now the way this epiglottis works, it just looks like a lid of a garbage can. So you know those garbage cans that you press down on those little footstep thing and then the lid comes up? This works in the exact same way. So when you're breathing, the lid of that garbage can will function just like this epiglottis where it's going to be facing up. And that'll allow that nice easy passageway from that nasal cavity through the pharynx right into the larynx. Now, when you swallow, what happens? As you swallow, you're going to raise this epiglottis. As you swallow, your tongue's pushing up against the surface of your mouth. And that, in turn, is going to be like the garbage can closing down. So you taking your foot off of that pedal for those garbage cans. And so as that happens, this epiglottis is going to come back down and block this entranceway of that food to enter into the larynx, and thereby preventing you from choking. Next structure we have is the trachea, which we also know as the windpipe. This is comprised, and we know this because it's comprised of the C-shaped hyaline cartilage. So this is that C-shaped hyaline cartilage. And also for those of you who are going to take Bio 130 in the fall, the lab portion, and you do your pig dissections, it's going to be the structure that looks just like that corner of a straw. So if you look at the straw, and you know sometimes this has a ribbed structure right here, the texture of that trachea and a pig is just like that. So even in yourself, it's going to be these nice ripples. Now, function of this trachea, we also have that nice mucous membrane lining it. And it's produced with that mucus and all that cilia, we can help expel any of those microbes or dust particles or pathogens trying to enter into our respiratory tract. Here's a cross-section of the trachea. And here is all of that cilia, nice brush border, trying to get rid of all of that, any particles coming into our respiratory tract. Posterior to this is the esophagus. And here we have that C-shaped hyaline cartilage. Now, of course, C-shape in order to account for the stretching of this esophagus. So as you swallow, what happens? This smooth muscles that are lining your esophagus wall are going to expand here into the lumen of your trachea. And because of that, well, how is this important if someone eats something very large? And how can this lead to choking? Well, how does this lead to choking? So if some eat a large portion of food, and it can come here into your lumen and thereby cut off the ability for your air to pass through your trachea into your respiratory tract. And so, of course, you have the Heimlich maneuver in order to remove any of these particles blocking your respiratory system and respiratory tract. Another thing also, why is it that people, especially older people who have lost their ability to swallow, you don't ever want to give them food or liquids, and why is that? Let's go up here really quick to that, where's that cross section of our esophagus, so in our epiglottis. Okay, so if someone who has difficulty swallowing, especially in older people, what happens then, you can allow that food to enter here into your respiratory tract, into that trachea. And why is that dangerous? Well, that can lead to pneumonia, especially if there's a lot of that liquids, a lot of that fluids entering into that alveolar space, which we're going to see in a little bit how those alveoli look like. But of course, if we have bacteria down that area, those bacteria, just like you, love nutrients, they love glucose, they need water, they need things to survive. And by providing them with those nutrients, they can end up growing down there and give rise to infections, respiratory infections. From here, we have the trachea. We're going to branch down. From that long windpipe, we're going to branch down into the bronchi. We have both the left and right bronchi. And it's going to meet into the lungs at what's called the renal hilum. So here we have that trachea, branch into the primary bronchi. And then from here we have secondary, so the much larger branches, tertiary, and then we have the bronchioles down below. If we look at the anatomy of the lungs, we're going to notice we have this pointed area called the apex and this wider broad area called the base. And this base is going to be closer towards our diaphragm. Also looking at the size of our lungs collectively, comprising majority of our thoracic cavity. But if we look at each lung individually, they are very different anatomically than each other, or from each other. And so our right lung is comprised of 3 different lobes. We have the superior lobe, the middle lobe, and then the inferior lobe. And to separate each of these lobes, we have fissures. Here we have the horizontal fissure. Here we have the oblique fissure. And our left lung is only comprised of 2 lobes, superior lobe and the inferior lobe. Here, because it's at this angle, this is also going to be the oblique fissure. Another unique structure or anatomical mark of this left lung is going to be the cardiac notch. And if we recall the anatomy and structure of that heart, the base is going to be pointed towards our right shoulder, and the apex is going to be pointed towards our left hip, so it's a nice little snug area for that to fit into. If you take a cross-section of our thoracic cavity and we look at the coverings of the lungs, you remember this pleura being that serous layer, meaning anytime we have an enclosed cavity lining an organ and the cavity itself, we're talking about those serous membranes. Parietal being this outermost membrane, pleura, dealing with lungs. And so parietal pleura is this outermost layer lining the thoracic cavity. And then finally, when it makes this U-turn and starts touching the surface of that organ, of the lungs, it's going to be called the visceral pleura. So here is that visceral pleura. And of course, this is what we saw already in chapter 11, our heart being housed in our visceral and parietal pericardium. Okay, so within our lungs, when we think about our lungs, we think about it as just one massive tissue, but in actuality, it's covering a lot of this anatomical structures that are going on inside. So a lot of the secondary, tertiary bronchi and a lot of many other bronchi. And really, it's filled with all of these alveoli where all that gas exchange is going to occur. And of course, you don't need to memorize and identify these. However, primary bronchi, of course, you know you have the right and left one. And then we have the bronchioles. Just know that those are the smallest ones prior to breaking into each of these alveoli. Here's a closer look at that. So we have this terminal bronchiole leading to our alveoli. And if you take a cross section of our alveoli, we can notice that they're connected to each other, and that's done by these alveolar pores. So alveolar pores allows connection between alveoli. Now, how many alveoli do we have per lung? Because it's critical for gas exchange, we have 150 million alveoli per lung. Pretty crazy. And of course, we notice that they have to be pretty thin in order for all that gas exchange to occur. And here is an illustration of all these alveoli, a cross-section of that, which is why they look very porous. If we take a closer look at this alveoli, we're going to notice a couple structures. We'll start off here with those alveolar pores that we saw earlier that allow the connection of gases between each of these alveoli. Another thing we have is a simple squamous epithelium, very nice and thin, also to allow that entrance of oxygen into our capillary bed and removal and disposal of carbon dioxide into our lungs. And also we have alveolar macrophages. And this is going to be used for the immune system response. Anytime we have pollen, anything foreign into our body, these macrophages are going to engulf it, bring it into our systemic blood flow, and then we can then destroy it and target it for destruction by our lymphocytes and our white blood cells. And what's also very important here, we have these specialized cells called surfactant secreting cells that produce surfactant. And why is surfactant important? Well, this is going to create a secretion comprised of lipids and proteins that are going to be necessary for reducing surface tension, at these alveoli, and it also assists in preventing the alveoli from collapsing. Oops. And why is it important? Well, these alveoli collapse, then your lungs then start reducing its ability to exchange gases. For the next couple of slides, we're going to go over respiration and how exchange of gases can occur at the alveoli level. And here's a quick illustration of how this is all going to look like. Here we have our bronchiole, our terminal bronchiole, and then culminate at our alveoli. And of course, we have all these capillary beds surrounding our alveoli to allow for that gas exchange to occur. Here's a closer look at those capillary beds coming into close contact with our alveoli. Here we have that simple squamous epithelium, and of course we have that basement layer right below it. Capillary bed, here's that capillary bed layer, also comprises simple squamous epithelium because we have to have all that exchange that occurs. The basement membranes in both of these are going to fuse, so that's what you see here in yellow. Now, the way that oxygen and carbon dioxide are going to get transferred across these membranes, it's all by simple diffusion. And if we remember, something at higher concentration is going to go towards where it's lower concentration. Because we're coming from our body, we are highly deoxygenated blood. So here we're going to have lots and lots of carbon dioxide within our blood capillaries going to our lungs. So from higher concentration here, low concentration of CO2 here, we're going to enter into our alveoli. Here within our lungs we have lots of oxygen. Within our blood in this area we have low amounts of oxygen. So oxygen is going to want to enter into our capillary bed. And this really allows for all that exchange to occur. For respiration, respiration deals with the movement and transportation of all that oxygen from our lungs and then bringing that finally to our cells and our tissues. And this respiration, this movement of oxygen and exchange for carbon dioxide to get rid of that, occurs in 4 different phases. We have pulmonary ventilation, external respiration, respiratory gas transport, and then finally internal respiration. When we first start off, we're going to look at pulmonary ventilation. Pulmonary, dealing with our lungs. And so this is the movement of air in and out of our alveoli. And because this is our alveoli themselves do not have any muscles, no smooth muscles, this is all a completely mechanical process that depends on the volume changes found within the thoracic cavity. So we're going to rely heavily on our diaphragm and our intercostal muscles. And those are the muscles found between our ribs. And by contracting or relaxing these 2 muscles, we can either increase the volume within our chest, within our thoracic cavity, allowing air to come in, or we can exhale by the relaxation of both of these muscles, thereby decreasing the volume and allowing air to come out. And so really it's the movement of these muscles that forces the movement of air in and out of our lungs. So we have 2 phases of pulmonary ventilation. We have inspiration or inhalation, and this is when air enters into the lungs. And we have expiration, which is exhalation, and when air exits the lungs. And inspiration, this is an active process, meaning that contraction is occurring. Expiration means exhalation, and this is all a relaxation process. Now, of course, you can also forcibly exhale and for your expiration, but that also will deal with contraction. However, under normal circumstances, when you are just relying on normal breathing, this is relaxation of your diaphragm and your intercostal muscles. So let's look at this first phase of breathing, and that's going to be the inspiration. And we're going to look at our diaphragm and our external intercostal muscles. And so during inspiration, both our diaphragm and our external intercostal muscles are going to contract. Here's your thoracic cavity, here's your diaphragm, and here are your lungs. Really bad drawing, I know. So as your diaphragm contracts, what's going to happen? This diaphragm is going to start flattening out. And as that flattens out, here's that thoracic cavity space. What's going to happen to all this thoracic cavity space? It's going to increase. Same thing if your ribs, your external intercostal muscles contract, you're going to open up the space of your thoracic cavity. So in turn, your volume is also going to increase because of that. So as you increase the space and the volume of your thoracic cavity, what's going to happen? So as these contract, you're going to increase intrapulmonary volume, meaning you're going to increase all that volume found inside of your lungs. And so what's also going to happen to your gas pressure? Well, if you have a lot more space for these gas molecules and gas particles, the pressure is going to be low. So it's going to have a decreasing effect in gas pressure. Let's take a look at that. Here we have those external intercostal muscles. This is going to contract. So as this contracts, this is going to go in this direction. This is going to go in this direction. It's going to widen this up. Diaphragm is going to flatten out. This full inspiration, this entire region of your thoracic cavity is going to open up more. How does this deal with this pressure? Here is normal atmospheric pressure, and here is volume. Let's start off with someone at rest. Okay, so when someone is going to inhale, the contraction, when you contract your muscles, what's going to happen to the contraction? You're going to increase your volume over time. So here is inspiration, contracting. As you contract both of those muscles, you're going to free up a lot of that volume. Because you have more volume, what's going to happen to that pressure? You're going to start decreasing all that pressure found within your thoracic cavity. However, after a while, what's going to happen to that pressure found within your lungs? It's going to be much greater than atmospheric pressure. And so once it becomes greater than atmospheric pressure, you're going to eventually exhale. So as you exhale, expiration, you're going to reduce the amount of pressure found once again within your lungs. And then here the volume of your lungs is going to decrease. And now another analogy of this is here if you have a small container, a small glass jar, and you fill this jar with, let's say, 6 molecules of oxygen, that pressure is going to be much greater compared to a larger container filled with that exact 6 molecules of oxygen. Now, if we're given these two examples, and you have more oxygen that you want to bring into these containers, which one is it most likely going to get into? It's going to want to get into this one, right? Because it has more space, more area. So same thing with your lungs. If you have more volume, because you have low volume within your lungs, you're going to allow air to passively enter into your lungs as your muscles then contract. Now, expiration, this is going to be a passive process, which is going to depend on your lung elasticity and the relaxations of your lungs. So as your muscles relax, both those external intercostal muscles and the diaphragm relax, what's going to happen? So here are your lungs. These lungs are full of air now. However, your diaphragm is going to relax. Your external intercostal muscles are going to relax as well. You have all of this pressure in here, but your space is starting to decrease. So where is that gas going to want to go? It's going to want to go out, right? So you're going to have a decrease in intrapulmonary volume. You have little volume here, and you're going to have an increase in gas pressure. And with these two factors, what are you going to do? You're going to force expiration. You're going to force all that air out. So let's look at that. So here we have those external intercostal muscles. They're going to relax, closing up and reducing the space within the thoracic cavity. Diaphragm starts closing that off. Here our lungs all filled with that air, Air has nowhere to go, more pressure here. So the key, once again, is if you have high pressure in your lungs compared to atmospheric pressure, so atmospheric pressure, much lower, lower pressure. Also, same thing with diffusion, high pressure wants to go to low pressure. So air is going to want to go out. Okay, here is that overview one more time of at rest, inhalation, and exhalation. So let's go over this one more time. At rest, we have normal amount of air and pressure in and out. So here pressure is equal. However, during inhalation, your external intercostal muscles contract. So here's initial at these dotted lines. We increase the space. Diaphragm flattens out. Because of this, initially we have atmospheric pressure is going to be higher. Pressure within your lungs is going to be lower. So because of simple diffusion, area from higher pressure wants to go to lower pressure. Also, we have lots more volume, reduced amount of pressure. Air is passively going to enter into your lungs. Exhalation, we have relaxation of these external intercostal muscles, relaxation of the diaphragm. Our volume is going to decrease. When our volume decreases, remember now we have all this air that came in, so now we have a higher pressure that we've generated. And this higher pressure that we generated is going to be greater than our atmospheric pressure. So by simple diffusion, high pressure in, low pressure out, air is going to want to go out. So once again, this passive movement of air is all because of the contraction and relaxation of these muscles. If we notice, there's other muscles involved in respiration. Those are the internal intercostals and the abdominal muscles. And this is where we're going to be using for exhalation. And if we notice here, we don't just necessarily have this normal breathing at rest. Sometimes you can we're told to inhale as much as possible and also exhale as much as possible, especially when you go see the doctor. So right now, as you inhale and exhale at rest, you take in and out about 500 milliliters at a time. And this is called your tidal volume. So this is the amount of air you'd bring in and out of your lungs at rest. Now, if you go to the doctor, someone tells you to take a deep breath in, all of this is your inspiratory reserve volume. And this is about 3,100 milliliters, so contracting your diaphragm to its fullest capacity and your external intercostal muscles to its maximum. Now, if someone tells you to force all that air out as much as possible, all of this is your expiratory reserve volume, and you notice your abdominal muscles are getting tighter, and this is when you utilize those internal intercostal muscles. And expiratory reserve volume has about a 1.2 liter volume. Okay, so even though right now you exhale as much air as you possibly can, you remember you still have all that air left within your alveoli. Let's just draw your lungs really quick. Wait, let's start over because I can draw. I promise I can draw. Here you have your trachea, your bronchi, and your alveoli. Even though you've contracted your external intercostal muscles and your diaphragm as much as you possibly can, thinking you gotten all that air out of your lungs, you still have all this residual air found here within your bronchi, your trachea, and your alveolar sacs. And so really there's never a time where you don't have any air at all within your respiratory tract. You can reduce the amount of air if your lungs are collapsed, but even here in your trachea and your bronchi, you're still going to have air. So residual volume, this is the amount of air left after forceful exhalation. Forceful exhalation. And so really there's never a time you're not going to have any air within your lungs, especially after you're born and you had that first breath. And so we can look at these different volumes and give them different terms. The total amount of exchangeable air is going to be your vital capacity. Now that includes all this air you can take in at most and all the air you can exhale. However, the total lung capacity, this is all that air that not only includes your vital capacity but also your residual volume. So make sure you know the difference between those two volumes. What can affect and change our different volumes capacities? We can look at a person's size, so someone who's much smaller compared to someone who's much larger. Also, metabolic state. Usually, smaller organisms have a higher metabolic rate, therefore, also need more oxygen and more air. Sex. Males have a larger lung capacity compared to females. Your age, once again, younger, needing more air, more respiration compared to someone who's much older. And also physical condition. So someone who exercises a lot is going to have a larger volume, practicing the inhalation and bringing in and expanding those lungs. How can we measure how much air we can take in and out of our lungs? We can do that using a spirometer. And this is something also you should do, and you will probably do in lab if you take Bio 130. Okay, other things that we can look at if we look at our respiratory system are respiratory sounds. This can be monitored using a stethoscope, and you can hear two different sounds of the stethoscope. You hear bronchial sounds, and these are noises made as air enters and exits the bronchi and the trachea. And you have vesicular breathing sounds, and this is when you can hear noises within the alveoli. And especially, what do you want to hear for? You want to hear if there's any obstruction, if there's a lot of fluid that can also signal that pneumonia, having your vesicles, your alveoli filled with that fluid, and not being very good because that can lead to infections of the respiratory tract. The second event in respiration is external respiration, which we saw earlier, and this is the movement of oxygen and carbon dioxide from the alveoli into the blood, or from carbon dioxide from the blood into the alveoli, and this is all by diffusion. Okay, so high concentration of oxygen to low concentration of oxygen. This bracket means concentration, so shorthand notation. So high concentration, the alveoli, to low concentration within the capillaries. Then we have high concentration of CO2 within the capillaries to low concentration of carbon dioxide within the alveoli. Third event of respiration is gas transport in the blood, and this is a form of how oxygen and carbon dioxide are going to be transported from those lungs towards our cells and tissues, or from our cells and tissues towards our lungs. Once oxygen enters from our alveoli into our blood, it's going to enter into our red blood cell, and it's going to combine with hemoglobin, and it's going to form this complex called oxyhemoglobin. So oxygen is going to attach to hemoglobin to form oxyhemoglobin. And this is the form, and it's going to stay here within our red blood cell until we arrive to our cells and tissues. Because in our lungs, if you remember our illustration at the lungs compared to our cells and tissues, at our lungs the concentration of oxygen within the plasma is going to be much greater than the cells and the tissues. So once we get the cells and tissues, we're going to have low amounts of oxygen. So when we go towards our cells and tissues, now we have this differential and concentration gradients of those gases. So we're going to have oxygen leaving our capillary beds to go towards our cells and tissues. At the lungs, we have low amounts of carbon dioxide. Once we get to our cells and tissues, we have lots of carbon dioxide. All that carbon dioxide is going to enter into our capillary bed and deliver that back towards our lungs. Carbon dioxide actually takes off a different form in that it's transported within our plasma in the form of a bicarbonate ion. So the plasma as a bicarbonate ion. And this is going to happen at the cellular tissue level. Once our cells and tissues produces carbon dioxide, and we're going to load that into our capillaries, it's going to combine with water, form this intermediate called carbonic acid, which is going to quickly dissociate and break down to form bicarbonate ion and hydrogen. Now this bicarbonate form is going to go around and circulate into our body until it arrives here within our alveoli, where it's going to go in the other direction. But for now, for this third phase of respiration, or of gas transport, in the blood. You just need to know that oxygen is going to combine with hemoglobin to form oxyhemoglobin, and oxygen is going to be transported in red blood cells. Carbon dioxide is going to combine with water to form carbonic acid. This is going to quickly dissociate to form bicarbonate ion and hydrogen, and this bicarbonate form is a predominant form that carbon dioxide takes form within the plasma. The last event of respiration we have is internal respiration, and this is exchange of gases at the internal level, so look between our tissues and cells and our capillaries. And this is an opposite reaction that occurs in the lungs, and that's because carbon dioxide is going to move from our tissues and cells towards our capillary bed, and all this oxygen is going to come from our red blood cells and load into our tissues and our cells. There's a specific term for this movement of these gases, and that's called loading and unloading. Anytime we put any gas into our capillary bed, this is called loading. And that's a movement of a gas into the capillary. And anytime we move a gas from the capillaries into our cells and tissues, this is called unloading. And so we can also load and unload at our lung level. So for the tissues between our lung and then also our capillaries there. So earlier we should have seen oxygen loading into our capillary bed and then carbon dioxide unloading into our alveoli. Oops. Let's briefly go over all these different forms of how we can bring carbon dioxide and oxygen in and out of our cells and tissues. So first, we're going to look at the steps of what carbon dioxide takes to get from our cells and tissues into our alveoli. And so carbon dioxide, what's going to do, it's going to, before we can form bicarbonate, it's going to enter into our red blood cell. And once it does that, it's going to fuse with a molecule of water. It's going to form this temporary transient state of being carbonic acid. And carbonic acid is going to dissociate or break into this bicarbonate ion and a hydrogen ion. From here, this hydrogen ion can complex with a hemoglobin molecule to form hemoglobin with oxygen. Alternatively, another form that carbon dioxide can take is it can just be free floating here within our plasma, and they can also complex with our hemoglobin molecule, although not a lot of that carbon dioxide actually complexes with hemoglobin, as most of that oxygen is going to complex with it. Once we circulate, so here's our tissue and cells level, so this is our tissue cells, here's our capillary, and this is our alveoli. As we circulate and we bring that blood back towards our alveoli and our lungs, now we have this form. Actually, let's take a step back really quick. Once this bicarbonate is formed, it's going to exit into the cell, and it's going to circulate in our body in this bicarbonate form found within the plasma. Okay. Once we get here, once that bicarbonate enters and gets close to our alveoli, it's going to enter into our red blood cell one more time. It's going to combine with a hydrogen molecule, form carbonic acid that's going to quickly dissociate into water and carbon dioxide, and carbon dioxide being a gas can easily get out of that red blood cell and enter into our alveoli by that simple diffusion. Okay, so also carbon dioxide complex with hemoglobin, it's going to dissociate, and carbon dioxide will again, of course, enter into our alveoli. So let's look at these steps. So first step is going to happen, carbon dioxide is going to enter into the red blood cell and combine with water to form carbonic acid. Carbonic acid is going to dissociate to form hydrogen and bicarbonate ion. And this bicarbonate ion is going to leave our red blood cell and circulate in the plasma. Now, once we get to and we arrive at our alveoli, we're going to do the exact opposite reaction. Bicarbonate is going to enter in the cell. And combine with hydrogen to form carbonic acid. And then here, carbonic acid will dissociate to form carbon dioxide and water. And what's carbon dioxide going to do? It's going to leave the cell by diffusion. Okay, so pretty straightforward. And just make sure you know the predominant form that carbon dioxide is going to take as it circulates the blood. Here's a quick reminder and overview of this concentration of oxygen and carbon dioxide from our lungs and also systemically to help you recall why is it that oxygen is going to enter from into our lungs at this capillary level of the alveoli. And then once we get to our tissues and cells, we have more carbon dioxide. So by simple diffusion, it's going to go in this direction. All this blood coming from our heart, and our lungs, lots of that oxygen. Here we have low amounts of oxygen. Simple diffusion going in that direction. Going back into our heart again, lots of that carbon dioxide. We're going to unload that. Here within our lungs, little carbon dioxide, lots of carbon dioxide. Simple diffusion, it's going to want to get out of the lungs. Here, lots of oxygen, low oxygen coming from our body. It's going to enter into our lungs. Okay, so all of those principles that we learned a long time ago. Let's take a look at the neuroregulation of respiration, and this starts off with two regions of the brain being the medulla and the pons. And the medulla contains a pacemaker called the self-exciting inspiratory center, and the function of this is to set the rate of respiration. We can do that by stimulating the phrenic nerves. Phrenic nerves in turn are going to cause our diaphragm to contract, and the intercostal nerves, which are going to cause the external intercostal muscles to contract, and all that nice tidal volume. Now we have another area, the pons, and what the pons does is help smoothen out all the respirations and every time we inhale and we exhale. We also have other controls and sensors within our body to help alter the rate of our inhalations and exhalations. The first one is a sensor for carbon dioxide. If we have lots of carbon dioxide in our body, this is actually the strongest signal that we have to breathe. And this is a direct effect on our medulla, and especially if that carbon dioxide is here within our cerebrospinal fluid. We can sense that drop in pH anytime you have lots of hydrogen. This is very acidic. And how do we get that hydrogen in the very first place? Remember, we have carbon dioxide plus water equals carbonic acid. And that's going to form to that bicarbonate and that hydrogen. So in turn, if we have lots of this carbon dioxide, we're going to go in this direction, and you're going to form lots of that hydrogen. And hydrogen is acidic. So anytime if something's acidic, it's going to have a low pH. So all this acidity is going to have an impact on that cerebrospinal fluid, which can then be sensed by the medulla. The medulla is going to increase your respiratory rate, so increasing the contraction of this diaphragm and external intercostal muscles. Another sensor that we have is for oxygen. Anytime you have a decrease in oxygen, that's going to get picked up by the aortic body of the aortic arch, and that in turn is going to cause us to inhale much faster. Looking at normal respiratory rates, we have 12 to 18 respirations per minute. Hyperpnea, this is if you have an increased respiratory rate due to extra oxygen needs. And this doesn't necessarily mean a bad thing. So this can be when you're working out. You're of course going to need more oxygen, deliver more of that oxygen to your cells and tissues. You also want to get rid of all that carbon dioxide that have you accumulated within your cells and tissues. Non-neural factors influencing respiratory rate and death. If you are hot, you're going to probably move yourself, try to fan yourself. Exercising causes you to have an increased respiratory rate. Talking and coughing, also other things influencing your respiratory rate. Conscious control, so you physically telling yourself to inhale or exhale, changing your respiratory rate. You having those holding your breath contests, also this volition. Going over hyperventilation and hypoventilation and the differences between this. Hyperventilation results from increased amounts of carbon dioxide in the blood, making the blood too acidic. Okay, let's go back over and how that's formed. Carbon dioxide plus water equals carbonic acid. That's going to dissociate into bicarbonate and lots of that hydrogen. And so with the hydrogen, increase in carbon dioxide will lead into this direction, increasing the amount of hydrogen. Anytime you have a high amount of hydrogen, once again, that means very acidic, having a low pH. How do you account for this? Well, if your breathing becomes deeper and more rapid, what happens? You're going to decrease the amount of carbon dioxide you have, thereby shifting this entire direction towards the left and thereby decreasing the amount of hydrogen that you have that's going to be present. If you don't have a lot of hydrogen, what's going to happen? So low amounts of hydrogen makes the pH of your body more basic, and that's how you can go from that more acidic environment to that more, to help neutralize it, so not making it more basic, but help neutralizing that pH to the physiological normal pH of the body. So you're blowing off all that carbon dioxide. How about hypoventilation? This happens when the blood becomes too alkaline, so it becomes too basic. If something is too basic, we don't have a lot of this hydrogen. So how do you create more hydrogen? Well, you want to increase this amount of carbon dioxide. So how can you do that? If you hold your breath, if you allow that carbon dioxide to accumulate and stay within your blood, then you can go in this direction. You can build up that hydrogen and make your blood more acidic, and that's how you can then go back to those normal parameters of your blood. Respiratory rate changes throughout your life. As a newborn, remember I mentioned earlier, the smaller you are, the more metabolic activity you're going through, and that being the case, the more respirations per minute as well. So in newborns, you have 40 to 80 respirations per minute. Infants, 30 respirations per minute. Ages 5, 25 respirations per minute. And in adults, we have 12 to 18 respirations per minute. What's interesting is that the rate of the respiration increases with age, and it's not that older people have an increased metabolic rate or activity. It's because of the elasticity of the lungs and the tissues surrounding the lungs start decreasing, thereby decreasing the amount of oxygen in their lungs. Another factor is lifestyle choices. So people who smoke have more ineffective alveoli for gas exchange to occur. And that being the case, you need to compensate for that by increasing respiratory rate to allow more oxygen into the body. Okay, this is it for the chapter 13, and I will see you in chapter 14.